Fit for dermoscopy. Welcome in this short video about head and face. So from our diagnostic eye, in which lesions we are interested in this area of head and face. And these are the most common lesions, and I want to share you my knowledge here, which it is helpful for me to use when I do it my clinical daily office practice. So important is to detect the melanoma in very early stage. Yeah, this is the most important thing, and we have here some different typical diagnoses in which we can learn when we are comparing. Yeah, and I always, when I use my dermoscope in the head and face area, before I use it, I use my finger, I touch it, and this knowledge I want to share with you. Flat, regular, yeah, and flat in touching. These are the lentigo simplex, lentigo solaris, and I like to compare this with this nice cookie from Vienna, Austria. Yeah, also flat but tricky in diagnosis is a lichen planus like keratosis, and it is always correct when you are not sure with the diagnosis, and you perform a biopsy, a shave excision or total excision. This pattern in dermoscopy, I like to compare it with the blue cheese. Yeah, and this is what very helpful for me when I touch this lesion. Yeah? It's a little bit like rough, a little bit like sandpaper, and so more and less regular pigmentation, and in dermoscopy typical for the actinic keratosis. Yeah, I touch it, and this lesion here, yeah, with patchy distribution, also flat in touching, and some initial donuts. And when we see brownish donuts, pigmentation around the hair follicle, yeah, we know something goes wrong, and this is a typical sign for lentigo maligna. That means in situ melanoma. Let us go to the next four pairs. Flat in touching, more and less regular, lentigo simplex. Very nice. Yeah. Flat, also a little bit smooth here. Here's the remaining part of the sepk, and here's the melanophage. That means the remaining part of the inflamed sepk, and that's in total the lichen planus like keratosis. When you are not sure, do surgery with histopathology. Absolutely correct. Rough in touching, yeah. So more and less regular pigmentation, rough in touching, yeah. So we have the pigmented actinic keratosis, yeah. Flat in touching but patchy in dermoscopy, yeah. Then we looked for the clue, and we see some brownish donuts here in this area, and grayish white lines, yeah. So we know something goes wrong. This is the lentigo maligna. Little bit tricky here for the lentigo simplex, lentigo solaris, the moth-eaten border here a little bit, but it is flat and more and less regular. Tricky lesion, very tricky. Remaining part of the sepk, yes, but a little bit pinkish and white lines. White lines we do not like, so to perform as a histopathology is absolutely correct. It was confirmed by lichen planus like keratosis. Yeah, rough in touching, and strawberry pattern in dermoscopy. We know actinic keratosis. Yeah, patchy, brownish donuts. Yeah, melanophage. Yeah, is this a lichen planus like keratosis or not? I'm not sure, but brownish donuts, that means tricky, a little bit patchy, yes. Are these brownish donuts? When we see these lesions, for example, at the head without hair here at the man, for example, yeah, but it is for me typical for lentigo simplex, lentigo solaris. Yeah, also very typical for the lichen planus like keratosis. Yeah, no hint for brownish donuts. Well, it's nice. Rough in touching, and very important, we see initial whitish donuts. And remember, whitish donuts is a sign for actinic, for keratin producing tumor. Yeah, that means the actinic keratosis is going to switch into the SCC squamous cell carcinoma. Yeah? Local treatment, yes. Control in 3 months, yes. And if it's some remaining part which is painful, we know the last painful island that we have the SCC squamous cell carcinoma. Yeah? And patchy. A lot of brownish donuts here, and when the donuts are closed, then we know we have the invasive lentigo maligna melanoma. Okay? Yeah? So in the next pair, I like to compare basal cell carcinoma with hyperplasia of sebaceous glands. Yeah? And we know, and here the vessels are the clue. Yeah? For the hyperplasia of sebaceous glands, we have crown vessels. Yeah? Surrounding this yellowish clots or globules, yeah, and here in this tumor we have the aberrizing vessels crossing the center is also a good differentiation hint for the basal cell carcinoma. Hyperplasia of sebaceous glands I like to compare a little bit with popcorn, yeah, and here 2 lesions at the forehead of this man, yeah. We see these lesions, and on the left hand side what do we have? Crown vessels, so that means with this yellowish parts, clots, globules, yeah, hyperplasia of sebaceous glands. Right hand side we have aberrizing vessels, a little bit of ulceration, yeah, and then we know we have the basal cell carcinoma. Yeah. And the next pair which I like to compare in head and face area is a keratoacanthoma and squamous cell carcinoma. Little bit tricky, but because we need to remove also the keratoacanthoma, and the nice hint are the hairpin-like vessels with this keratin plug in the center, which I like to compare with a muffin. We have also a muffin here, right hand side, but remember, whitish areas, whitish donuts, yeah, here at the periphery, and that means keratin producing tumor in the direction of squamous cell carcinoma. Yeah. Also here, you know this lesion, but on the right hand side it is much more smaller. But what is the hint? Yeah, whitish donuts, a little bit polymorphy of vessels, yes, but whitish donuts. So that means that we have here the initial squamous cell carcinoma, and we need to do surgery, especially when it's painful for the patient. Yeah. So you know the management decision, when we are not sure, we do not like the lesion, we cut it out, send it to histopathology. But when we say it is benign, we must say the benign diagnosis for the patient in our file, yeah, to be sure everything goes wrong. And when we are able to name the lesion with the help of dermoscopy, then we have our diagnostic eye. So happy to see you soon in Palm and Soul in Dermoscopy. See you.